So here, first case, and the reason why I bring this up is I was just very intrigued. Case I did recently, 48-year-old female, 3-year history of loss of upper extremity dexterity, progressive gait unsteadiness. You can see here left upper T2's weighted T2 signal. You can see T2 signal changes within the spinal cord. She underwent on neurological examination. She had left deltoid weakness, hand intrinsic weakness, unsteady gait, and we did a 2-level ACDF with HAP cages. And again, with these procedures, as you will know, during your training and afterwards, there's an incredible variance what people do: end plate preparation, bone harvest. And so I try to keep it extremely simple with these procedures. So the only thing we do is HAP cages and DBX into the insert of the cage. So nothing else, no bone graft, nothing. And this is the 3 months. I just had to put that up because I've never seen anything comparable to that. So if you look at the 3 months X-ray, you can already see bridging bone in the back. And also I used to use allograft, and you typically saw a little bit of a halo around the graft. And we just don't see that commonly anymore. But again, this was a case. As a case, she's 3 months out roughly. And already at the 3 months follow-up, we saw a nice bony bridging. Sig, have you seen those bone formation that early in your practice?
Well, I think, Christoph, that's terrific. I think that's a testimony to both your skill at end plate preparation as well as perhaps a device that you use in creative media stability. But yeah, that's not common in my practice. I wish I could say that I see that often. I've been using a lot of structural allograft in my ACDFs most commonly, to be honest, and yeah, I'm not reliably seeing that early.
Yeah. And so, and then I have a second case, similar story, really. Also a female, 51-year-old female. Again, also, as you can see up there, T2 signal changes, severe stenosis, intrinsic hand muscle weakness, left Babinski, unsteady gait. And in her, we did a C5, C6, C6, C7 HAP DBX anterior plate. And this is a 1-year follow-up, so a little bit more like expected. But again, I'm really intrigued by, we've now used this for 2.5 years, the system. And before that, they used allograft and combined with cellular allograft. So solid allograft combined with cellular allograft. And so far, again, we're collecting the data and hope to contribute to the database, to the registry. But it's going to be interesting to compare these cases and sort of see what the outcome is going to be. Here's one lumbar case that I have right now. I just wanted to bring that up here. Here we have a CT scan in this patient too. A 58-year-old female, 1-year history. Again, I like to do standalone A-lifts. I think this is just, if patients don't have pars fractures, and it's possible, it's my go-to procedure there. And you can see the nice bridging bone there. Again, absolutely no halos, and a nice fusion that's a year out. So those are the 3 cases. Again, very straightforward cases that I wanted to share that we have here that we're collecting. So I want to give back to you, Sig.
Yeah, terrific, Christoph. I appreciate you sharing those cases. And I wonder, a very nice job on the cervical spine. One of the troubles I've recognized in the cervical spine, certainly with my ACDFs, is I typically use a fresh frozen allograft. Recently, we've had to use some freeze-dried allograft, and I've really had trouble with the brittleness of some of the freeze-dried allografts. Have you had trouble with implant breakage on insertion with either, certainly with the HAP? I haven't seen it, but with other materials?
I have to say that I'm pretty aggressive in reducing basically the subluxation of the disc space. So I use these disc spreaders in the cervical spine and really reduce the height quite aggressively. And while the patients do have a couple months of mid-scapular pain with that, I feel that it's worth it because you can restore the anatomy. And so if the graft, once the graft goes in, it's pretty loose because it's loosened. I think there was one thing. I think, I tell that my fellows and my residents all the time is that, I could probably do an ACDF in 40 different ways. I've seen people do it in so many different ways. Drilling the end plate, scraping the end plate, distracting, not distracting, weight, no weight. I mean, it's crazy. What I found from my experiences, I think, and I've seen it, I'm not going to say that rare, but I think being aggressive on the end plate and drilling the end plate is really the worst you can do. I think the end plate is really, it's like a TLIF. I mean, once you've lost the end plate, the surgery is gone. I mean, you're not be able to restore that. So I think being very, very vigilant with the end plate and having a wide graft. I think the nice thing about those peak grafts that they're pretty wide, 16 millimeters wide, and some of them are even, I think there's even one that's a little wider. And so it's very different from an allograft ring. I used to use allograft rings, but I have to say that while our fusion rate was pretty good, you do see subsidence, and you see these cages that are kind of, not very well integrated, let's say it like that. So you'll see. I mean, it's definitely, I think it was a step forward. But again, we're collecting the data and we're going to analyze it really case by case.
Dr. Hofstetter, there was a question for you. You see the type of bone growth you're seeing with DBX on your cervical cages. What type of biologic are you using when you use these for ALIF?
ALIF, we use, I do typically use DBX and an extra small BMP with ALIF. So the smallest size BMP that is, it's I think it's 1.05 and DBX. Is it necessary? I don't know. Honestly, that's why I'm very, Nathan kind of figured it out. So yes, so I do use for my ALIFs, I use a small, extra small, so it's 1 milligrams of BMP, and then basically I hold it in place with DBX. Is it necessary? I don't know, but that's kind of what I've done historically, and have not. I like to. I don't like to change more than one variable when I change my practice, and evaluate it for at least a year, and then sort of change things again. So I think do you use BMP with your ALIFs? Sig?
I do in my ALIFs, but I don't tend to use BMP in the cervical spine.
Yeah, so same. How much do you use per level?
Generally, I'll use a large kit, and so a large kit is 12 milligrams, and I'll tend to use a third of a large kit per level, so 4 milligrams per level, and I mix it with a non-compressible matrix. Okay.
So yeah, I use the smallest level. I don't, again, I think up to 8, I did this, we published this meta-analysis many years ago, which was quite a lot of work. And we saw that more than 8 milligrams a level, you get osteolysis. So I use the smallest dose. I've not seen any issues. I think the therapeutic window is, we're overshooting a little bit with that drug, but we'll see. I think it's going to be interesting once we see those fusion rates, I think, and it's well established. I think I might completely omit it for my ALIFs. I think it might not be necessary.
So the promise of some of the novel surfaces is to really try and be bone graft sparing, and because there's certainly, we all recognize some of the potential complications that may come from different materials, and certainly one of my one of the reasons that I'm reluctant to use BMP in the cervical spine has to do with the potential complications in the cervical spine and in other areas, and, including the posterior interbody. So to that end, having a interbody graft that may be more actively contributing to the fusion can be useful. So let me transition now to just a couple of cases that I selected. This is a patient that I managed several months ago now. A patient with a bit of a thoracolumbar kyphosis, perhaps equally impressively, or maybe even more impressively, who was fused with distraction instrumentation. So many of you recognize this as a semi-rigid fixation here from L3 to S1. And this was used as a stabilization rather than as a fusion. So the patient had a laminectomy, a stabilization with distraction. You can see here the end result is that from L3 to S1, the patient's really at best neutral, perhaps even a little bit kyphotic, and then kyphotic up above there. So the end result is now we've got a patient who on a standing film, the C7 plumb line is pretty impressive. So the C7 plumb line still falls about 12 centimeters of the sacrum, but the plumb line itself perhaps underestimates the extent of this patient's deformity. So this is a patient with a significant retroversion of the pelvis, a very, very vertical sacrum here. And this patient actually has 42 degrees of pelvic tilt, so a very compensated posture. Now, this is a case where with posterior dynamic instrumentation, initially my temptation, but not fused. I think I've got a CT scan next to show you, or maybe I don't. The CT scan was meant to show that the facet joints were open here. But this is a case where you might think about doing a 3-stage surgery, maybe taking out the instrumentation in the back, then going to the front, and then going to the back again. Or if this patient were circumferentially fused, in my hands, I would tend to do a 3-column osteotomy on this. But in fact, and I regret that the CT scan's not there. I'm not sure where that disappeared to. But what I saw in the CT scan is that the patient actually had some vacuum changes within the disc when they lay supine, and the facet joints weren't even decorticated, so there was no attempt at a posterior lateral fusion. So what I ended up doing here is actually in a same-day surgery is I went, I'll show you in the lateral. So I went anteriorly. In this case, it was a 4-level anterior. I went from L2 down to S1. I could do this typically through a paramedian incision. So I went anteriorly from L2 to S1 and placed lordotic cages in there, really trying to restore lordosis, especially from L4 to S1. So L4 to S1, which had really been a pretty parallel prior to surgery, trying to really restore 2/3 of my lordosis from L4 to S1. And then just with simple posterior-based osteotomies, posterior column osteotomies, you see how effectively we were able to get some segmental lordosis all the way from L2 to S1. And again, what was interesting about this is I did the anterior stage of surgery without taking out these interbody cages. Vincent Darley from Penn had shown us that he's able to, in some cases, really overpower posterior implants. It can be difficult when there's a really solid posterior fixation. It's easy if there's a pseudoarthrosis in the back, and in this case, there was no fusion at all. So I was able to really restore a nice overall balance in this patient from pre-op to post-op. And in this case, I used the HAP composite cage. You notice here a subtlety I'll point out is that I didn't actually put the screws on both sides. So the cage itself has the ability to gain fixation to both end plates. What I tend to do when I'm going to do posterior-based posterior column osteotomy is that I tend to put 2 screws into one end plate. So there's 2 screws into the sacrum here, 2 screws into, in this case, L3, 2 screws into L2, 2 screws into L1. Where you notice how I didn't lock my alignment of the end plates together here. And by not locking into both end plates, that really enabled me to use these interbody grafts as a fulcrum through which I gained more correction with my posterior column osteotomies.
So, sorry for interrupting here. This is such a neat, great technical detail that you point out there. It really, I can't tell you how often this has saved me for A-lifts and for lateral approaches so that the graft doesn't spit out. One other thing that I like to do for this is when you size these A-lift grafts, that you kind of don't go for the maximum size that you can put in there, but just one size below, and that gives you much more flexibility than to close it down in the back. So I think at the beginning, what I did, the mistake there is that you really try to oversize these grafts. And yes, you want to have highly lordotic grafts, but then size them just a smidge below what you could possibly get in there. And that allows you then to collapse it nicely in the back. Have you noticed that, or is it?
Yeah, that's a very good point, Christoph. Thanks for bringing that up. And one of the things about sizing the grafts that I really tend to do pretty aggressively is especially when I'm trying to put in grafts that are more lordotic, so a 24 degree graft, for example. So especially when I go for my more hyperlordotic grafts, is I really, first of all, make an effort to get my posterior height. And typically, I like to have at least 7 millimeters or 8 millimeters of posterior height. And for exactly that reason that you indicated, Christoph, is that I don't want to create foraminal stenosis. So I'll do my discectomy, and oftentimes in a patient with a really collapsed disc, that'll involve taking down the posterior longitudinal ligament and the annulus off the end plate below. I'll get my posterior height first, and only then will I really dial in my lordosis. And I think that the Innovasis instrumentation kit has some very nice tools that allows you to shim up sequentially with the posterior height first. And I'll start maybe even with a 4 millimeter shim to get my posterior height. And then I'll actually dial in my lordosis after getting my posterior height.
Yep.
And really, as you suggested, avoiding getting too much foraminal stenosis. So many times there's the temptation to put in a hyperlordotic 24-degree ALIF cage that might only be 4 millimeters high in the back. And I really worry about inducing foraminal stenosis there.
Yep.
We don't have much time, so I'll show one more case briefly, a very similar theme, but this is a patient with more of a primary deformity without the implants in the back. But again, what I want to emphasize here is my goal in reconstructions is to really try and induce lordosis from L4 to S1. And again, this is a similar technique. In this case, again, using the unilateral screws, getting lordosis and getting, in this case, almost 40 degrees of lordosis from L4 to S1, really trying to get most of my distribution lordosis there. That's an important strategy to avoid junctional kyphosis.